This presentation will review the anatomy of the 12 pairs of cranial nerves, their palsies, i.e. their weaknesses, and those cranial nerves leading to strabismus, a part of neuro-ophthalmology. And we'll mention the palsies of the other non-ophthalmologic cranial nerves. The focus is on the anatomy and not necessarily the pathology of all the disease processes which can cause a palsy of the cranial nerve. Welcome to this presentation on cranial nerves, their palsies, an introduction to strabismus, and a review of the extra-ocular eye anatomy. This is a complex topic, and I've relied on Dr. Timothy Root's website and 3 important videos he's created to help explain this topic. I made generous use of the images from the TEMA Atlas of Anatomy 4th edition for this presentation. I've also included a 20-minute video on anatomy of the eye, which should be helpful as a review and to understand neuro-ophthalmology. If you don't own it, you should purchase a copy of Dr. Goldberg's Clinical Neuroanatomy Made Ridiculously Simple. It's now in its 6th edition and in color. These, quote, made ridiculously simple, end quote, books have been around since I was a medical student. Don't think they're challenging your academic ego. The Neuroanatomy book is, in my opinion, a must for every student who wants to pass their neuroanatomy course in medical school. A few sentences supporting the neuroanatomy were taken from Young and Young's textbook, Basic Clinical Neuroscience, the 3rd edition. And if you can afford it, I would strongly encourage you to purchase references number 2, 3, and 4 to use for board study. Don't rely on this PowerPoint as your only tool for board study. In addition, the most interesting and best produced videos are 2 videos I've included by Dr. Timothy Root from his website, as I mentioned. His website, entitled Optho Book, where he explains the cranial nerve palsies that affect vision. Want to learn what a Bell's palsy is right now? Click on the link to George Clooney's explanation. These overarching learning objectives cover the basics of this presentation. In addition, we'll look at a teaching learning issue for each individual slide. You'll need to memorize the 12 cranial nerves, and they're not minutia. You'll test the function of each nerve in your physical examination, and you'll need to know which nerves are sensory, motor, or both. There's mnemonics to help you learn each of them. Here's 2 mnemonics to get you started, and I hope you find useful. For the cranial nerves, on Old Olympus, topmost top, a Finn and German viewed some hops. And another mnemonic to remember which nerves are sensory, motor, or both. Quote, some say marry money, but my brothers say big business matters more. The letter of the first word in each of the mnemonics gives you the name of the cranial nerve, for example, on Old Olympus, and whether the nerve is sensory, motor, or both. Some say marry money, etc. We'll define all these terms later. Let's read these 2 learning objectives. Number 1, describe physical examination findings consistent with an upper motor neuron lesion versus a lower motor neuron lesion. And demonstrate the physical exam maneuvers designed to test for intact cranial nerve function. The learning issue here from this slide, can you identify which cranial nerves are being tested in these photographs? Dr. Ackland presents Anatomy of the Eye and Surrounding Structures. This clip is taken from his DVD online series called Ackland's DVD Atlas of Human Anatomy. It's about 20 minutes in length, and the TCU Medical Library has the entire collection for you to peruse. Click on the link above to review the gross anatomy of the eye. It's about 20 minutes long, but worth the viewing time. Learning issue for this slide, can you explain the gross ocular anatomy of the eye? Here we define palsy. In short, it's a weakness of a nerve, often with accompanying loss of feeling. It can be acquired or congenital. The cranial nerves have significant palsies, and these are most notable among the trochlear, abducens, facial, hypoglossal, and the oculomotor nerves. We will discuss each of these in the presentation. And systemic diseases such as multiple sclerosis, diabetes, and meningitis can also cause palsies, which leads to how we manage the palsy. We need to know its cause as its first step in management. So, our learning issue here, what is a palsy? What cranial nerves are the most commonly affected by disease processes leading to palsies? Remember, palsies can be treated and reversed if the nerve is not permanently damaged. However, addressing the cause is the first step in management. I know this is a busy slide, but we'll go through it one by one slowly. It turns out it's a really important slide schematically. If you can understand this slide, you'll understand most of what the cranial nerves do. Let's name each cranial nerve and pay attention to where on the brainstem it exits, on the ventral surface of the brain and the brainstem. The olfactory and optic nerves are technically not true cranial nerves because neither leaves the cranial vault. Those first two cranial nerves are purely sensory, while the third cranial nerve, the oculomotor nerve, is motor. The fourth cranial nerve, the trochlear nerve, also a motor nerve, innervates the superior oblique muscle of the eye. The trigeminal nerve, with 3 associated ganglia or branches, is a mixed nerve providing sensory and motor functions to the face, branches V1, V2, and V3. The inferior turbinates of our nasal passages and the muscles of mastication for chewing, obviously a motor function, are all functions of this trigeminal nerve and its 3 branches. The sixth cranial nerve, the abducens nerve, innervates the lateral rectus muscle of the eye. That's it. It's a motor nerve to that muscle only. The facial nerve is a sensory and motor nerve to the face for muscles of facial expression and taste to the anterior 2/3 of the tongue, and innervation to the parotid gland. Facial nerve also innervates the lacrimal glands and sensation to the inferior aspect of the turbinates, which overlaps with the trigeminal nerve. Cranial nerve number 8, the auditory nerve, i.e. the vestibular cochlear nerve, provides sensation for hearing, the hearing apparatus, and balance, the cochlea and its associated parts. Cranial nerve number 9, the glossopharyngeal nerve, innervates the salivary glands, i.e. the parotid gland, submandibular glands, etc., and muscles that allow us to swallow, and the inner portion of the hearing apparatus. Hence, if you shove a Q-tip far enough into your ear canal, it will elicit a cough, but it isn't the only nerve that innervates the ear. The 10th cranial nerve, the vagus nerves, innervate via parasympathetics the autonomic nervous system of the heart, lungs, the stomach, and the intestines. The 11th cranial nerve innervates the trapezius, allowing you to raise and lower, i.e. shrug your shoulders. And lastly, cranial nerve number 12 innervates the inferior portion of the tongue, motor function. Our next slide demonstrates in order which nerves are only sensory, motor, or both. Learning issue for this slide, name the 12 pairs of cranial nerves. If we make the premise a palsy comes from a weakness of the affected muscle, then any cranial nerve with motor or muscular innervations should in theory be prone to develop a palsy. 3 of the cranial nerves are considered sensory. In truth, most are not purely motor or sensory, but for our purposes and for ease of learning them, it's close enough for clinical examination and evaluation. How can you remember the cranial nerves? Well, 2 mnemonics, which I alluded to earlier. One is old-fashioned, and the other I offer also for educational purposes. To help remember the cranial nerves, remember this mnemonic. On old Olympus, towering tops, a Finn and German viewed some hops. Now, how do you remember which cranial nerves are sensory, motor, or both? Mixed. Again, I offer a mnemonic as an educational aid. Some say marry money, but my brothers say big business matters more. The learning issue for this slide, identify each cranial nerve by whether it's considered sensory, motor, or both. This chart from Clinical Neuroanatomy made ridiculously simple should be memorized. First, note, however, the slide is broken down into the sensory, motor, and mixed, or both nerves. Somatic motor fibers innervate striated skeletal muscle. Somatic sensory fibers innervate predominantly the skin, muscle, and tissues other than the viscera. It's best to think of the autonomic nervous system as consisting of visceral sensory and visceral motor components. This will make more sense as we move forward. The sympathetic nervous system, as you recall, is the fight or flight response, increasing the heart rate, contractility, and moving blood to the striated muscles when you run, and the cardiac muscles. It's a catabolic system. The parasympathetic system, i.e. cranial sacral nerves, is an anabolic system. It slows the heart and promotes digestion and absorption of food by slowing the movements of the gut. In other words, the existence of a parasympathetic system is like the brakes on an automobile. It's the hypothalamus that's believed to act as the master controller over the autonomic nervous system, whereas the cerebrum controls the somatic motor system. Learning issue for this slide: identify whether a cranial nerve is sensory, motor mixed, and whether the motor component has a somatic and or a visceral component, and whether the sensory component has a visceral and or a somatic sensory component. This one-page download really gives the necessary information that you'll need as a medical student to understand the cranial nerves and to help you perform a relevant physical exam. You can double-click on this page to download this chart as a PDF. Note the chart gives several areas of information you'll need to understand the anatomy of the cranial nerves. Not only does it give the nerve, it gives the function of the nerve, where it's located in the brainstem, through which foramina of the skull it exits, and of course the distribution and associated nuclei. The learning issue for this chart: use this chart to learn the cranial nerves, their functions, where they're located on the brainstem and where they exit, or if they exit, the skull, and if so, by which foramina. Now, as a generalization, you can say the first 4 cranial nerves are part of the midbrain. The cranial nerves 5 through 8 are part of the pons, and 9 through 12 are part of the medulla. Of course, this classification isn't totally correct. Cranial nerves 1 and 2 do not exit the cranial vault and aren't, hence, really cranial nerves. Cranial nerve 4, the trochlear nerve, where this arrow points, innervating the superior oblique of the eye, is the only cranial nerve that exits posteriorly, dorsally, from the brainstem. It's unique in that way. Note cranial nerve 7 is close to the superior salivatory nucleus, which makes sense since cranial nerve 7 plays some role in salivation. The inferior salivatory nucleus is adjacent to cranial nerve number 9, the glossopharyngeal nerve. And one other weird relationship. Note how the nucleus of cranial nerve 12 is more superiorly located in the medulla than is cranial nerve 11. You'd think, by the way they're numbered, 12 would be more inferior than 11. It isn't. Learning issue on this slide: describe where the nuclei of the cranial nerves are located, the midbrain, the pons, or the medulla. Here's the same information, just a different view. We're looking at the posterior, the dorsal view of the brainstem. How do we know? Because cranial nerve 4, the trochlear nerve, can be seen exiting the brainstem on its dorsal posterior surface. Also note how cranial nerve 7, the facial nerve, how its nucleus wraps superiorly around the nucleus of the abducens nerve, cranial nerve 6. A patient presenting with a facial weakness and a palsy or a weakness of the lateral rectus could have a tumor, an aneurysm, or other pathology at this point in the brainstem. The learning issue from this slide: how is cranial nerve 4 different than the others in regard to its exit from the brainstem? And what's unusual about the path of cranial nerve 7 in regard to the nucleus of cranial nerve 6, the abducens nerve? In this image here, cranial nerve number 2, the optic nerve, can be seen as a purely sensory nerve entering the optical canal, and V1, a branch of the trigeminal nerve, a mixed nerve, is innervating the lacrimal gland. We're building a picture so you'll understand palsies of the visual apparatus. The learning issue on this slide: explain why cranial nerve number 2, The optic nerve is often said to not really be a true cranial nerve. What's the difference between the optic nerve and the ophthalmic nerve, i.e. V1 branch of the trigeminal nerve? Here's one of the few reasons you took chemistry in college, so that you'd understand chemical equations. In this case, we read this as LR6, SO4, remainder 3. We'll build on this knowledge to understand the palsies of strabismus. But what does this mean? The lateral rectus is innervated by the 6th cranial nerve, the abducens nerve. The superior oblique is innervated by the 4th cranial nerve, the trochlear nerve, and all the remaining extra-ocular eye muscles are innervated by the 3rd cranial nerve, the oculomotor nerve. Learning issue: use this very important mnemonic and explain the innervation of the eye muscles. The strabismus flowchart is applicable to only a few of the cranial nerves. We'll look at several cranial nerve palsies that can be seen in strabismus. But what is strabismus? Well, a Johns Hopkins medical website defines it as hypertropia and crossed eyes, causing one eye to deviate inward, esotropia, toward the nose, or outward, exotropia, while the other eye remains focused. So our learning issue here on this slide defines strabismus. What's esotropia and what's exotropia? We're just going to focus on the anatomy of strabismus. Those disease processes leading to the pathology of cranial nerves will be covered elsewhere in your curriculum. Here we see strabismus being broken down into acquired types and pseudo-strabismus. Of the acquired types, we have several different presentations of that type of strabismus. We won't go into all of these. It's not necessary at this level of your education. The learning issue, on a basic level, explain the ocular mechanics between exodeviation and esodeviation of the eye. Cranial nerve 3 is purely a motor nerve. It innervates 5 muscles: the superior, inferior, and medial rectus muscles of the eye, and the inferior oblique. Like the image on the far right of this slide, we can see how cranial nerve 3 acts like pillars holding the eye open. A weakness or palsy of cranial nerve 3 will cause a drooping of the upper eye, called a ptosis. A palsy of the 7th cranial nerve, the facial nerve, could result in the inability of the patient to keep the eye closed, causing a perpetual drying of the eye. I've also highlighted the substantia nigra, where dopamine is produced. Some pronounce it as the substantia nigra. It's lack of dopamine or pathology in this area of the brainstem that can cause Parkinson's disease. Our learning issue from this slide: what eye muscles are innervated by the 3rd cranial nerve? What's the function of cranial nerve 3 in regard to opening or closing of the eye? What's the function of the 7th cranial nerve in keeping the eye closed? What is the substantia nigra? What chemical is produced here? And what is Parkinson's disease? The optic nerve, purely motor, can be seen leaving the globe. The lateral rectus muscle, LR6, is innervated by the 6th cranial nerve, the abducens nerve. That's all it does, is innervate this muscle. Cranial nerve 4, the trochlear nerve, i.e. SO4, innervates the superior oblique muscle, helping to pull the eye down and somewhat out. The muscle of the superior oblique runs through the trochlea. A small pulley on the medial upper inner surface of the cranial orbital fossa. Dr. Root explains this in a few upcoming video clips that I took from his website. To review, the image here shows us the innervation of all the eye muscles. LR6, cranial nerve 6, innervates the lateral rectus. SO4, the superior oblique, is innervated by the trochlear nerve, and all the remaining muscles of the eye and the eyelid via the levator palpebrae superioris muscle are innervated by the 3rd cranial nerve, the oculomotor nerve. So our learning issue on this slide: explain the function of the 3rd cranial nerve and the extraocular eye muscles that it innervates. In this image, try to understand the pulley system of the superior oblique, the trochlea, and the inferior oblique. Note where those two muscles attach to the eyeball. The superior oblique attaches superior laterally, and the inferior oblique attaches inferior medially. Can you understand that if the superior oblique contracts, it rotates the eye medially and somewhat down, whereas the internal oblique, when it contracts, pulls the eye laterally? The vessel is the internal carotid. You ever see the pulse in your retina when you close your eyes? Sometimes even when your eyes are open? Our learning issue here. Discuss the innervation of the extra-ocular eye muscles by the third cranial nerve, and what's unique about the trochlear nerve nucleus, and how its fibers exit the brainstem. We've removed the anterior cranial fossa to see the ocular apparatus. This is the best view of the superior oblique muscle, the trochlea, and the fourth cranial nerve, SO4, the trochlear nerve. Remember, it's the trochlea, the pulley, that changes the vector forces of rotation of the superior oblique muscle, causing the outward and down movement. Again, our learning issue here is related to all of this. Address the anatomy of the eye by listing all the eye muscles, what nerve innervates them, and what the trochlea is. These illustrations are taken from Clinical Anatomy Made Ridiculously Simple. They're good visual mnemonics. Look at how the cranial nerve, number 7, acts to close the eye, while cranial nerve 3 acts to keep the eye open. So if you have a palsy of those muscles, see how the eyelid closure mechanism is affected? Then, if we understand, cranial nerve 3 also innervates not only the eyelid, the levator palpebrae superioris muscle, but parasympathetic fibers from cranial nerve 3 would cause the pupil to constrict. Parasympathetic fibers here cause pupillary constriction. The dilator muscles, those radial rays, are innervated by sympathetic fibers from the superior cervical ganglion of the neck. And those fibers would cause the pupil to open, consistent with our flight or fight response. In other words, when you're afraid, your pupils open wide to make sure that you can see the bear you're running away from on that camping trip. Our learning issue here, explain the functions of the third and seventh cranial nerve in relation to opening or closing the eye, and their function on the diameter of the pupil. What role does the superior cervical ganglion play in these functions? If a patient has a weakness of cranial nerve 3, the oculomotor nerve, here's what we'll see. The inability of the eye to stay open, hence ptosis occurs, and you have a drooping of the eyelid. The pupils dilated, overactive fibers of the superior cervical ganglion compared to the parasympathetic fibers of cranial nerve 3, which constrict the pupil, causing pupillary dilatation. And the entire eye falls down and out, allowing the lateral rectus to act stronger than usual. And the same is true of the fourth cranial nerve, the trochlear, causing the eye to be pulled slightly down. So our learning issue for this slide, what are the common findings in a palsy of the third cranial nerve? Here's a slide showing the same thing with the explanation. The affected eye, in this case, the right eye, is affected by ptosis, dilated pupil, and a down and out rotation of the eye because of unopposed action of the lateral rectus and the superior oblique muscles of the eye. There are several causes of this physical examination finding. A few are listed on this slide. The learning issue, what are the findings and common causes of a palsy of the ocular motor nerve? What is ptosis? What is mydriasis? Why does it occur with a palsy of the third cranial nerve? All of these images are made clear on the next slide, but the take-home message here, cranial nerve 4, or trochlear nerve, arises from the dorsal surface of the brainstem before it eventually comes around to the ventral surface of the upper pons. So our learning issue, what's unique about the nucleus of cranial nerve 4 in relationship to where the fibers of the trochlear nerve exit the brainstem? This image is focused on showing how the trochlear nerve arises from the rostral portion of the pons, dorsally first, and then eventually it comes around on the ventral surface of the brainstem, like the other cranial nerves do. This is what makes cranial nerve 4 special. Oh yes, and the nuclei cross. The right nucleus of cranial nerve 4 is to the left of the dorsal midline, and the left is vice versa. So our learning issue for this slide: where is the nucleus of the cranial nerve 4 located in relationship to the other nuclei located in the pons? So here we have a palsy of the trochlear nerve causing a weakness of the superior oblique muscle, resulting in a contralateral eye torsion, an outward rotation of the superior part of the eye, which the patient compensates for by tilting the head slightly downward. If the palsy is bilateral, double vision with a torsional, i.e. a rotated double vision, occurs. This is hard stuff. Dr. Root's video coming up will help. So here are some causes of a trochlear nerve palsy. Trauma, of course, diabetes, atherosclerotic disease, high blood pressure, thyroid disease, and myasthenia gravis, to mention a few. So our learning issue: with your understanding of the nuclei of the fourth cranial nerve, can you explain how a bilateral palsy would occur? The definition given here is from the New England Journal of Medicine's review article. They define trigeminal neuralgia, also known by its old term as tic Douloureux, as chronic neuropathic pain disorder characterized by spontaneous and elicited paroxysms of electric, shock-like, or stabbing pain in the region of the face, restricted to the territory of one or more divisions of the trigeminal nerve. In this slide, we see trigeminal neuralgia is not really a palsy. It isn't a weakness of the nerve. Rather, it's sharp, piercing, stabbing, intermittent pain in an area innervated by the fifth cranial nerve, most commonly in V2 or V3. The diagnosis can be difficult, as it is often not reproducible, yet it does remain intermittent. There have actually been suicides reported because of this persistent but unrelenting intermittent pain. Oddly, it rarely wakes the patient up in the middle of the night. The diagnosis is usually made by high-resolution MRI using IV gadolinium with contrast, or by trigeminal nerve reflex testing, which is rarely done. Once the diagnosis is confirmed and hopefully the cause can be found, then the treatment can be instituted. The treatment of choice today is medical, Tegretol or its derivative, oxcarbazepine, which has fewer side effects. In rare recalcitrant cases that do not respond to medication, surgery, such as a rhizotomy, may be performed. Radiofrequency ablation, balloon dilatation around the nerve to create more space for the nerve, or gamma knife surgery can be done. None of these are free of side effects or complications. The images here remind us of the distribution of the trigeminal nerve with an endoscopic view of the superior cerebellar artery, which is the most common vascular compressive culprit, being wrapped with either gauze or Teflon to prevent any pressure on the adjacent trigeminal sensory nerve root. I have to admit, and I do want to ask, doesn't adding the Teflon cause pressure also? I would think that this wouldn't be a really good treatment if you're trying to relieve pressure, but I couldn't find anything to answer that question. All references suggest surgery would be a last-ditch effort. Our learning issue on this slide: what is trigeminal neuralgia? What is the most common cause? How is it generally diagnosed? And how is it generally treated? Here, cranial nerve 6, the abducens nerve, which innervates the lateral rectus muscle, sits near the floor of the fourth ventricle. Let's look at the next slide for a better image. Our learning issue for this slide: where in the brainstem is the nucleus for the abducens nerve? And remember, the abducens nerve innervates only the lateral rectus muscle. Here, cranial nerve 6 arises at the caudal end of the pons, where the medulla and the pons meet. let's see what a palsy looks like of cranial nerve 6. So our learning issue here, where does the abducens nerve exit the brainstem? Cranial nerve 6 controls the lateral rectus muscle. If there is a weakness of this muscle, the medial rectus acts more prominently and pulls the eye inward, called an esotropia. The image shows such a medial deviation of the eye, i.e., an unopposed action of the medial rectus muscle. So our learning issue for this slide, what would a pure palsy of cranial nerve 6 look like? Please open up your PowerPoint to slides 30 and 31 to review Dr. Root's lectures on neuro-ophthalmology. I think his explanations are excellent, and I think you'll enjoy these 2 video clips that will help clear up any confusion that you may have in the information up to this point. Now let's take a look at a complicated nerve, cranial nerve number 7, the facial nerve. Here's a mnemonic to help you learn the branches of the facial nerve. 2 Zanzibar bimotor car. We have the temporal branches, the zygomatic branches, the buccal or cheek branches, the mandibular branch, and of course the cervical branch. What's our learning issue here? Name the 5 branches of the facial nerve, and is the facial nerve sensory, motor, or both? So here we have a different view of basically the same information. Note how the facial nucleus, giving rise to the facial nerve, wraps around cranial nerve 6's nucleus, the abducent nucleus. What is the importance of the salivatory nucleus and the solitary tract nucleus fibers in forming the facial nerve? You may have to go to the several slides earlier in this presentation to see the answer, but we'll get to it more. So for the function of the superior salivatory nucleus, the solitary tract, and the nucleus ambiguus, they're explained pretty well in clinical neuroanatomy made ridiculously simple. The genu of the facial nerve, shown by the large arrow here, lies in the pons, and other 3 components lie in the medulla. The superior salivatory nucleus, the visceral motor component of C7, controls the nerve's ability to lacrimate and salivate. The nucleus of the solitary tract, the visceral sensory component of cranial nerve 7, 9, and 10, provides taste to the anterior 2/3 of the tongue and sensory input from the carotid sinus and the carotid body from cranial nerve 9, and massive sensory return along the vagus nerve, cranial nerve number 10. This is a lot of information, so let's talk about some of the clinical relevance. The learning issue for this slide, how could a tumor affecting cranial nerve number 6 affect the facial nerve? And why is this? Is the solitary tract motor or sensory? And is the salivatory tract motor or sensory? So the facial nerve, or its fibers, serves to innervate the lateral aspect of the tongue through the chordotympany nerve for taste, the parotid gland, and the lacrimal glands in tear formation. The petrosal nerve is also important in hearing apparatus through branches of the stapedial nerve, and of course with mucus formation. Remember, the salivatory nucleus spits and cries. So here we see the chordotympany in a patient's right ear. When a patient has pus in the inner ear, or a child needs to have ear tubes to drain an infection in this area, the ENT surgeon drains the pus through the inferior aspect of the tympanic membrane to avoid damaging to the chordotympany, which would then cause damage to taste fibers for the anterior 2/3 of the tongue. So this slide's learning issue. What is the chordotympany? What does it innervate? What is the path of the chordotympany? And between what structures does the chordotympany pass in the middle ear? And how is the anatomy of a Bell's palsy defined by the parameters of the internal acoustic meatus and the stylomastoid foramen? Remember, cranial nerve number 7 innervates the salivary glands above the oral fissure, mucus glands of the nose, and lacrimal glands. It helps with salivation, tear formation, mucus formation, closing the eye, hearing, taste, and sensation. It's pretty important. So here, just a different view again of the middle ear. It's in this area where the Bell's palsy occurs, a weakness of the facial nerve for reasons that we don't truly understand. The important structures are highlighted. Note the all-important chorda tympani, carrying fibers to the anterior two-thirds of the tongue, and it merges with fibers of V3, lingual nerve, which is a branch of the trigeminal ganglion. The large red box marks the area where a Bell's palsy occurs, and we'll get to that in a minute. So our learning issue for this slide: define the relationship between the trigeminal ganglion, its branches, the facial nerve, the chorda tympani, and the innervation of the lingual nerve to the anterior two-thirds of the tongue, providing taste. So this is just a different way of looking at the same information. Between the internal acoustic meatus and the stylomastoid foramen is a pathology that arises in a Bell's palsy. Note the chorda tympani, a branch of the facial nerve, joins with V3 from the lingual nerve to provide taste to the anterior two-thirds of the tongue. The chorda tympani runs between the incus and the malleus of the inner ear. Then, arising out of the stylomastoid foramen is that branch of the facial nerve that goes to the facial muscles, the muscles of facial expression. Whereas the trigeminal nerve powers the muscles of mastication. So our learning issue: where is a Bell's palsy pathology believed to occur? What symptoms would a patient have? And we'll be able to answer this in more detail in just a second. Here's the complicated anatomy again put together. Spend some time on this image until it's clear for you. Our learning issue here regarding the facial nerve: describe the relationships between the facial nerve, the trigeminal nerve, and their various functions, and as they are related to facial expression, taste, either muscles of mastication or facial expression, the lacrimal glands, the submandibular glands, and the potential for hyperacusis in a Bell's palsy, which is explained in a later slide. What is hyperacusis? It's where noises sound much louder than they are and can also be a ringing in the ears, like tinnitus. So let's look a little bit more at lesions of the facial nerve. Here, if we follow these figures, we can illustrate the difference between an upper motor neuron lesion and a lower motor neuron lesion to cranial nerve 7. If one severs cranial nerve 7, which innervates the entire side of the face, including the eyelids and eyebrows, that entire side of the face becomes paralyzed. The forehead on the affected side appears ironed out and flat. The eye won't close, remember the hook analogy, and there's flattening of the nasolabial fold. On the other hand, if a patient suffers damage to the supranuclear or an upper motor neuron lesion, as in a stroke, we can usually see that only the lower portion of the face is affected. Let's take a look at this. So if the lesion is above the level of the nucleus, i.e. an upper motor neuron lesion, only the area of the face below the eyes is paralyzed because there is bilateral innervation of the upper face by the two cerebral hemispheres. Hence, in a typical stroke patient with an upper motor neuron lesion rarely needs a tarsorrhaphy, which is an operation to keep the eyelid closed so it doesn't dry out. Whereas a patient with a Bell's palsy may, because of marked difficulty in closing the eye. So our learning issue: what's the differences between the lesions affecting an upper motor neuron nucleus of the facial nerve and a lower motor neuron lesion? Which one's unilateral? Which one's contralateral? Which one affects the upper and lower face? And which one affects only the lower face? I don't like reading slides, but on this one I might have to. So let me read this to you slowly. This motor nucleus of cranial nerve 7 is divided into two parts: the part that innervates the upper facial muscles and a larger part that supplies the lower facial muscles. Interesting, the neurons in the dorsal aspect of the facial motor nucleus receives inputs from both sides of the cortex, while those in the ventral aspect mainly receive contralateral inputs, i.e. from the opposite side of the cortex. The result is that both sides of the brain control the muscles of the upper face, while the right side of the brain controls the lower left side of the face, and the left side of the brain controls the lower right side of the face. Let's make some more sense of this. So for a facial nerve lesion distal to the stylomastoid foramen, this is a point which causes damage on the same side of the entire face, whereas a stroke centrally, an upper motor neuron lesion, affects the opposite side and only the lower half. Make sense? So the entire half of the face is damaged to the nerve, but if it's only half of the face, the lower half below the eyes, it's an upper motor neuron lesion on the opposite side of the cortex of the observed damage. So I don't really think you need to memorize this chart as it is. It's just a summary of what we've already spoken about. Read the chart slowly. Think about each area of the facial nerve, branch, and nucleus. Slowly digest this information. Some relatively famous movie stars suffer from Bell's palsy. We'll take a look at them in a second. George Clooney, Katie Holmes, and a guitarist for Def Leppard, Rick Savage. Bell's palsy is the most common cause of facial muscle weakness and cranial neuropathies. Intracranial and or internal auditory meatus, cranial nerves 7 and 8 are affected, which can result in hyperacusis of sound. The geniculate ganglion, pain behind the ear, and then if someone has herpes of this part of the nervous system, herpes of the nerves to the eardrum and external auditory meatus may cause this. The facial canal is affected, as we've seen in previous pictures, resulting in loss of taste in the anterior tongue, decreased salivation on the affected side, and that's due to chordotympany involvement, and then hyperacusis due to an effect on the nerve branch that goes to the stapedius muscle. And if the lesion is below the stylomastoid foramen, for example, the parotid gland tumor or from trauma, facial paralysis, the mouth draws to the opposite side. On the affected side, the patient's unable to close the eye or wrinkle the forehead. And then food can collect between teeth and the cheek due to paralysis of the buccinator muscle. So when a Bell's palsy improves, return of function is often accompanied by crocodile tears, in which the patient tears up on eating instead of salivating, owing to misguided growth of the regenerating salivatory and lacrimal fibers. So our learning issue, using all the knowledge of anatomy of the facial nerve at this point, explain how a Bell's palsy would present. What is the most common cause, and why is hyperacusis possible? So let's talk a little bit about a Bell's palsy. Mentioning Def Leppard, the rock group, brings up some interesting trivia for us. Their drummer, Rick Allen, lost his left arm in a car accident, and he plays the drums very well with his feet and his remaining right hand. Rick Savage, the bass player, suffers from a Bell's palsy. And as we've just learned, he might suffer from hyperacusis because of involvement of the geniculate ganglion in some cases. It must be very difficult for him to listen to loud music with a Bell's palsy if he does suffer hyperacusis. So just for fun and to give you a break, I posted a song from Def Leppard called Promises as a small tribute to Rick Savage and allowing us to learn from his medical condition. Just click on the speaker icon. Of course, George Clooney suffers from it also, as does Katie Holmes, and of course, Rambo, Sylvester Stallone. So the nucleus of the hypoglossal nerve, as we move on from the facial nerve, is in the medulla. The nerve supplies the muscles of the tongue and is considered a motor nerve. So our learning issue here, from what part of the brainstem does the hypoglossal nerve arise? Where does it exit the skull, i.e. the hypoglossal canal? Is it motor, sensory, or both? And what does it innervate? Over on the right, I've given you an image of the homunculus, the somatosensory cortex, and the motor cortex, the prefrontal cortex, to help you figure out exactly the function and whereabouts of the hypoglossal nerve and its nucleus. So the learning issue on this slide, as we look at the hypoglossal nerve and cranial nerve number 12, is what does the hypoglossal nerve innervate, and how would a weakness present? So for the hypoglossal nucleus, we see it's adjacent again to the fourth ventricle. It exits out as the hypoglossal nerve in the medulla, and the rootlets pass ventrally through the medulla and emerge at the pre-olivary sulcus. Along the route, it lies next to the medial lemniscus and the pyramidal tract. Cranial nerve 12 supplies the ipsilateral muscles of the tongue. Let's take a look. The hypoglossal nerve supplies motor innervation to the ipsilateral tongue. A lesion of this nerve proper results in the contralateral side overpowering the weakened damaged nerve and pushes the tongue to the side that's been damaged. We call this that it points to the side of the lesion. So our learning issue here on this slide, how does cranial nerve 12 palsy present, and how can you examine this nerve's functions? There are 3 sets of muscles that are innervated by this nerve proper. Can you name them? So what is the most common cause of a cranial nerve palsy? It's malignancy, and it is usually an ominous finding. Is the palsy ipsilateral or contralateral? Well, it's the same side. So what we see in these images here is the lower motor neuron lesion, a defect of the nerve proper, causes atrophy on the same side of the lesion, allowing the normal, stronger side to push the tongue, as we say, to the side of the lesion itself. The tongue deviates towards the affected side. Causes of this malignancy, number 1, trauma, a stroke, hysteria, psychological etiology, surgery, Guillain-Barré, infection, and multiple sclerosis. So let's talk about a bulbar palsy. What is the bulb? Well, the bulb refers to the medulla and the pons together. So don't forget the clinical signs of a lower motor neuron lesion, which include flaccidity, fasciculations, atrophy of muscles, paralysis, and diminished reflexes secondary to the flaccidity. And then signs of an upper motor neuron damage, increased reflexes, hyperreflexia, and spasticity of the muscles. So as we look at what a bulbar palsy is, if we know the bulb is the medulla and the pons, it refers to a lower motor neuron lesion of the nerves themselves, i.e. the bulb refers to the medulla and pons. If you'd like to see a really nice video that explains this, please click on this link to a YouTube video which explains the difference between bulbar and pseudo-bulbar palsy. So a bulbar palsy refers to those nerves that are located in the medulla or pons. Cranial nerves 10, 11, and 12 are involved. And then from the nuclei distal to the end organ, that's a lower motor neuron lesion. So we see diminished gag reflex. The tongue appearance and movement has fasciculations and it might atrophy. The jaw jerk reflex is probably normal because jaw jerk is tested with cranial nerves 5 and 7, and they're not involved in a bulbar palsy. The speech can be raspy, unilateral vocal cords can be involved, and water regurgitation through the nose, a loss of control of the soft palate. So what's a pseudo-bulbar palsy? I got to read this to you. A pseudo-bulbar palsy means paralysis of swallowing and phonation as a result of bilateral upper motor neuron lesions. So a pseudo-bulbar palsy means there is an upper motor neuron lesion, bilateral, with paralysis of muscles and phonation, affecting the muscles of mastication and expression. Cranial nerves 5 and 7 are unique to the pseudo-bulbar palsy. So our learning issue for this slide: what is a pseudo-bulbar palsy? What cranial nerves are unique to a pseudo-bulbar palsy? Is it bilateral or unilateral? Why? And what functions are affected by the paralysis? Swallowing, phonation, both, or either? So let's conclude on how to test the functions of the cranial nerves, and that's a good place to end our discussion. This book is awesome, and the video by a doctor of nurse practitioner is very short, sweet, to the point. If you'll click on this video, she shows you in just a minute or so how to do the cranial nerve exams. So our learning issue from this slide is perform an exam of the cranial nerves in 4 minutes or less. The book is outstanding and the video's short, quick, and sweet. Thank you for listening. Appreciate your attention.